Well, it's good to see everybody. I thought we could just take a minute to go around and just tell us who you are and, where you're zooming in from and what your job is. And we don't have to spend a ton of time on introductions, but just to kind of give a sense of who we have today. And then we might have more people join too, I think, as they get done with warm handoffs over lunch and other things like that. So I'm Matthew Tolliver. I'm a psychologist, behavioral health consultant at ETSU Pediatrics in Johnson City, Tennessee. So I help direct our behavioral health program in the pediatrics department here. And I'm one of the co-chairs of our SIG this year. Jackie, do you want to introduce yourself?
Hi, I'm Jackie Borhan. I'm the membership and conference manager for CFHA. So I tend to have a lot of the answers to questions if people have them. So you can send them to me if you do.
Hey, Anne-Marie.
Hi, I'm Anne-Marie Madison, and I'm a licensed clinical social worker, behavioral health consultant at Northeast Pediatrics with Jessica Connor. I'm really excited about today's topic because I think I used to go to 0 to 3 conferences a long time ago, and so happy with how that organization has grown and all the exciting things are happening. So someday I hope to get to the in-person conference again, but today is wonderful. So nice to meet you all.
Great, welcome. Jessica.
Jessica Connor, clinical psychologist by training, behavioral health consultant here at Northeast Peds in Ithaca, New York.
Great. Arissa.
Hi, I'm Arissa Wahlberg. I was originally the lead psychologist for Peace Health in the Oregon network. So I'm located in the Eugene Springfield area. I started that in pediatrics a year ago, and now have moved into the managing psychologist for integrated behavioral health for the whole Oregon network. So also doing that for family medicine. So kind of leading that charge there. So excited I get to do this. I got a little more admin time with that position, so I can join you guys more regularly, hopefully.
Nice, yeah. Glad to have you. Jennifer?
Hi, everyone. I'm Jennifer Mautone. I'm at Children's Hospital of Philadelphia, school psychologist by training, but I've been here on the hospital side for about 17 years. Trained in integrated care. I wear a number of different hats in our integrated care initiative here. One is as a BHC, but also I'm the Associate Director of Primary Care Behavioral Health Research here at CHOP, and so do a bunch of different work evaluating our integrated care model and providing mentorship and training to others looking to conduct research. And yes, I finally joined CFHA. Hello, Cody. I've been involved in APA, American Psychological Association, Society of Pediatric Psychology. Know some of you through there. Lisa, we're just getting involved in launching Healthy Steps here. We have a pilot, so I've been connecting with some of the 0 to 3 gang down there. So really excited to get to know more of you in this way.
Great. Glad you can join us. Rachel?
Hi, everyone. Rachel Petz. I am research chair here for the PEDSIG, and I'm an assistant professor at Fairleigh Dickinson University in New Jersey, and I do some research and clinical training in pediatric integrated care at the doctoral level.
We're so thankful to have you on the leadership team. Cody? We're just introducing ourselves.
Hi, I'm Cody. I'm at Nationwide Children's Hospital. This is Donna. She's our fellow who was at CHOP for internship.
Hi, Donna. It's so great to see you.
So we're at Nationwide Children's Hospital. I spend some of my time doing integrated primary care clinically, and then some of my time training physicians in behavioral health competencies, and then some of my time providing technical assistance to practices in the community who either want to integrate or who are integrated but want to change things up or work on some things together.
Yes, and Cody was our co-chair last year for the SIG and is awesome. I'm glad we could make that reunion happen between the CHOP folks there. Courtney?
Hi, everyone. I'm Courtney Valentine. I'm a behavioral health consultant for the Yakima Valley Farm Workers Clinic in Central Washington. I'm also a school psych by training as well, and yay for us. And I'm the Washington State lead for the BHCs in our organization across Oregon and Washington. So nice to see you all.
Great. Allie? Oh, we can't hear you, but you're off mute. We'll come back to you. Work on that and we'll come back. Louise?
Hi, everyone. I'm Louise Chan. I'm a psychologist in BHC in Columbus, Ohio at Pediatrics Associates, which is a private primary care office with 5 different offices, and we currently have 5 BHCs and looking to expand. So I'm happy to be here today.
Great, welcome. And Lucy?
Hi, I'm a Behavioral Health Division Director and in a FQHC here in Columbia, South Carolina. We have 21 clinics. Our team right now of BHCs is 8, but the goal is ended up in so having a BHC in each clinic, so between 17 and 20.
Great. You want to give it one more try, Allie?
How about now?
Oh, yes, we can hear you.
Okay, good. Good afternoon, everyone. My name is Allie, and I work for Summit Health in New Jersey as an integrated behavioral health clinician. And I've been in this position for about 8 months. Prior to that, I was very unfamiliar with integrated behavioral health. So I'm loving it, and I'm glad to be a part of the CFHA.
Welcome. We don't always do introductions every month, but we like to do them every now and then because part of our goal is to be able to help people network together, right? And get to know each other. And there's a lot of variety, I think, in the types of training and job descriptions of the people in the SIG. And so we wanted to be able to let you get to know everybody. Jess, did you get to introduce yourself? I think you just, okay. Well, we are so excited to have everybody today. We try to pick a new theme each month, and for the year, we've tried to have a theme around addressing the pediatric mental health crisis that's going on. And we're going to have like a culminating kind of ELO at the conference this year. So if you're going to come to the CFHA conference in October, you can see our leadership team and hopefully other people from the SIG during that if you're interested in signing up for it. And yes, Jess was just putting her introduction in the chat. So thanks for that. She's at Geisenberg and she's part of our leadership team as well. So we've tried to have a different theme every month, but kind of all related to that broader overarching theme. But wanted to introduce Lisa Powell, who's going to help facilitate our talk and our time for today, focusing on prevention, healthy steps, and early intervention, that kind of topic. And I think it's perfect timing for that kind of thing. So the way we structure these, usually we'll have kind of this warm-up introductory period. We'll sometimes hear from one of you all or like an expert in the field and kind of give us a sense of what you do and a little bit more in depth and how you do it, kind of a this is how we do it segment. We have a research segment that Rachel will lead us through here in a little bit, and then just a facilitated discussion around the topic of the day. So we're really informal. Feel free to ask questions throughout. Feel free to eat lunch throughout. It's totally fine. So Lisa, can I hand it over to you to introduce yourself a little bit more and kind of kick us off?
Sure, thank you. It was fun to hear where everyone's from, so thanks for that. So my name is Lisa Powell. I'm a pediatric psychologist by training, working in integrated care for a long time. I started an integrated behavioral health program in Louisville, Kentucky in a peds primary care clinic. And I think we had a really great program, robust services, but I kept saying to our PCPs, What's happening with our younger kids? I'm not getting referrals. We had that population is half refugees, half kids in foster care or out of home placement. So lots of high needs, and yet we were waiting. We were waiting until things were really significant before we did anything. So I started shopping around the country for an evidence-based program to bring to our clinic, and found Healthy Steps. So I still am doing some part-time clinical work, and I joined 0 to 3 and Healthy Steps in 2020 to work on training pediatric primary care practices and implementing the program, and then also working on the policy and advocacy work around sustainability for early childhood mental health. So I'm the state lead for Massachusetts. I focus on all things Massachusetts, where there's been a lot of excitement. So I'll mention a little bit of that as well. So I thought what I'd do is just spend a couple of minutes and just give you a little bit of an overview. I do have just like 4 slides. It's easier for me, and hopefully our visual people will appreciate just having a little bit of a slide. So I'm going to share my screen. And everybody see that okay? Okay, great. Okay, so I'm going to talk really briefly today about 3 things. One is I was just going to sort of re-ground us in the Surgeon General's report, and really focus a little bit on what are some of the barriers to implementing the great recommendations that he put forth. Then I was going to tell you a little bit about 0 to 3 and Healthy Steps as a way to sort of operationalize those recommendations. And then finally, I just thought I would mention some policy and advocacy efforts to address some of those barriers. And I could talk about this for hours and hours, so I will try to be brief and just, and then we'll go to some discussion. So again, just to re-ground us, these were the recommendations that Dr. Murthy put forth in response to the behavioral health crisis. So I want to talk again about some of those barriers, because these recommendations are amazing, and yet there are also some real challenges in terms of implementing them. So we all know this, right? It's difficult to do preventive work. We have a system that's so diagnostically focused that we really force kids to fail into services because we don't grant access until there's clinically significant levels of impairment. So of course, this flies in the face of everything that we know about earlier identification and treatment, and how it leads to better outcomes, particularly in the when we know how important those first few years of life are. So 1 is the challenge of prevention. 2 is that some of the recommendations, for instance, with regard to screening, we know are so important. AAP has said this for how many years now, and yet we know that the data suggests that only 37% of PEDS primary care practices are screening. And that's really just for development, not even, it's lower for social emotional health, for family and caregiver needs. And there's lots of barriers that we all know, right, about implementing universal screening. Also, a barrier is that we still live in a system that really treats caregivers and children separately, right? Even our own providers sometimes think, oh, the child is my patient, not the parent. So it really is about transforming our thinking and our systems to be able to provide care that accounts for children and their caregivers. And then finally, we all know this all too well, that the payment structure, namely fee for service, really doesn't lend itself easily to the kind of collaboration with other child serving agencies, and even within our multidisciplinary teams often. So it's hard to sustain the recommendations that are made here, and it's really hard to implement and sustain programs like Healthy Steps. So I'm going to talk a little bit about what we're doing in that space. So just really briefly, just to tell you, Healthy Steps is a program of 0 to 3. There's a couple of policy arms to 0 to 3, as well as clinical programs. So Healthy Steps is one of them. It's an evidence-based model. It is interdisciplinary. It's focused in primary care, and it really is centralized around putting a child development behavioral health expert onto the team, which we refer to as the specialist. The focus of the program is birth to 3. I will say many of our clinics focus up to 5, depending on the patient panel size and really the bandwidth of behavioral health providers. But we really focus on this period, like I said, where there's the most risk to the developing brain and body, and when there's the most opportunity, right, to build that kind of resiliency and protective factors that we know are so important. It's also a time where we know many families face the most hardships, right? We know that children are most likely to be abused and neglected in the first 3 years of life. In fact, 50% of ACEs we know are in the first 3 years, and we know that 80% of brain development is occurring here. So this is the time, right? It's a 2-generation model. It's prevention focused. We're really working on, again, enhancing caregiver capacity to engage in early relational health activities with the child, and also trying to mitigate some of those impacts of toxic stress on kids. So again, I mentioned the practice transformation. So we work really hard with practices to really help to build out, their full continuum of behavioral health services that includes promotion and prevention, not just intervention, and that includes children across the lifespan, including from birth. So you all know all of this, I won't go into it, but just to say what we really are focused on is the frequency of the visits, right? That we have this enormous opportunity in the first 3 years of life to really impact change, right? When we know that kids are coming in much more frequently than they ever will when they are older. So Healthy Steps intentionally focus on that practice transformation. We're focused on behavioral wellness for the entire 0 to 3 patient population and panel at a practice. We really are trying to shift that focus again from pathology to behavioral wellness across that continuum. It's, of course, family-based, right? So the child is not the patient, the dyad, the child giver caregiver dyad. Child caregiver dyad is the patient. So we're really focused with practices on really building out in an intentional and structured way their infant early childhood mental health services. So we, again, like the Surgeon General's report, are trying to shift to this culture of doing something when there's a crisis, right? And getting ahead of that and shifting to promotion and prevention, but certainly to rising risk, not just clinically significant risk. So what that might look like in the room or in terms of interventions, we have 8 core components, but we're really, again, focused on caregiver needs. Are there caregiver mental health needs? Are there caregiver or family basic social needs that we need to address first? So supporting the caregiver to support the child is always where we start. And then we really, again, it's a 2-generational approach. So we're focusing on providing dyadic interventions in the room, right? Building early relational health and responsive caregiving. So we do this in real time, where we teach and coach and partner with families on observing cues that kids are giving, responding contingently, building capacity for serve and return interactions, really focusing on positive parenting. So lots of interventions that occur either within short-term sort of consults with us or within the structure of a well-child visit. So we risk stratify, we have different tiers of service to determine intervention dosing, but for families for whom we have the most concerns, we are partnering to do a team-based well-child visit for every single visit in those first 3 years when we know there's concerns. The goal is always to get in as soon as possible. So if we have a newborn that we can partner with the family because we already know that there is maternal depression, or even because we are in family medicine clinics and we know from OB that there are concerns, that's always best case scenario. So we'll partner even before mom has delivered, and certainly at the newborn visit. So I want to just briefly revisit some of the barriers that I mentioned in terms of the recommendations, because they're the same barriers that we face every day when we try to work on the policy and advocacy side in terms of sustainability. So I'll just mention to you some sort of buckets of work that we're doing. So one is really around advocating for prevention and early intervention without requiring a diagnosis, right? This is critically important for this age group. We're trying to prevent diagnoses, but we certainly need to ensure that we are intervening way earlier than our current system allows. So we've had some good success. There are many states now that are allowing for services without a diagnosis. I'd say California is probably the most innovative and the most progressive in terms of allowing. They have defined sort of at-risk conditions, and those include social determinants of health, you know, risk of homelessness even. I mean, so again, really trying to go as upstream as we can to be thinking about providing services at the earliest possible time. Colorado has a preventive benefit, and Massachusetts, which I told you is where I focus all of my work. We were really happy, considered it a big win in September. They also introduced Mass Health. This is Medicaid, I should say, too. Introduced a preventive benefit for 6 sessions as well. So that's a huge piece of our advocacy at 0 to 3 is access to services without a diagnosis. Another broad area for advocacy is around the behavioral health well-child visit. Ohio and Colorado are already doing this through a pilot, which they're doing really great things. California has moved to approve this. It's coming in 2023. And there's, again, very expansive. It will be true parity for behavioral health finally. And theirs is all focused, again, on dyadic services and on well-child visits. Maryland actually just in the past couple of weeks has approved what they call an enhanced well-child rate for practices that are implementing healthy step services. So there's lots of different ways that we are going about trying to institute the behavioral health well-child visit. Many states, actually, you all have probably seen this, have legislation that is for an annual well visit, which is a good start. But for pediatrics and for young children and prevention, we are working really hard to try to advocate that that is including all of the Bright Futures well-child visit schedules, that the behavioral health providers should be able to team with PCPs to do those. I mentioned a barrier. You all live this every day. You know how hard it is to work in a fee-for-service environment when we're trying to do this kind of work. So we are advocating in many different states for value-based payment and working with state Medicaid agencies to pilot different programs for what that might look like. Massachusetts, again, I know this state the best, but they are really innovative in terms of transitioning to a fully value-based payment. They did this in the last iteration. They're doing it through the 1115 demonstration waiver. They did it in the last iteration, but it really only benefited adult care. And so this is heavily focused on families and children. And instead of, you know, a fee-for-service world that really disincentivizes us from working as a team, this actually requires team-based care, integrated behavioral health, and care coordination. It's a beautiful proposal, and it will go into effect in 2023, where practices will be paid a higher per member per month for how sophisticated basically their levels of integrated care are. So lots of innovation on the value-based payment space as well. And then finally, I thought I just mentioned that even at the federal level, we're seeing some really good traction and some good initiatives. Some of you may have seen just the past few months, the Transforming Pediatrics for Early Childhood grant. This is out of HRSA, and they will be announcing actually next month, in August, which states receive this TPEC grant. And this is for placing a provider to focus on early childhood mental health in primary care. It's a smaller grant. There were only 4 states are going to be awarded, but I'm really excited that in June, they announced, HRSA did, that $85 million is in the president's budget to place an early childhood mental health specialist in community health centers. So hopefully it'll be much broader in the years to come, and many more federal initiatives that are focused on early childhood. I'm going to stop sharing there and just see, first, I know that was a lot very quickly. So what thoughts and questions you have, and then I'm really interested to hear from you all about what you're doing in the early childhood mental health space in your practices, what kind of services you have for families, and where you all are.
So here in South Carolina, in cooperative health, we have parents as teachers. I believe we have 3 or 4 serving all the 21 clinics. And the providers identify families that need the services and refer them to them. We have, let me see, there's 3 of us working in different PEDS clinic. But the most challenging, I think, is like 0 to 10. From 0 to 3, we just get referrals from providers when parents start complaining about behaviors or maybe picky eating. And after that, we have the PSC 17, but it's still, we have the same issue of low referral numbers, knowing that the behavioral and mental and social problems with the PEDS in the PEDS population is much, much higher.
Thanks, Lucy. Yeah, that's helpful. I'm always interested, like I said, when I started our integrated behavioral health program and just pulled the data on, how many referrals I was getting for kids that were under 5, they really were all really in 2 buckets. The data was really clear. One was developmental delay, mostly concern for autism, or 2-year-olds with tantruming and behavior dysregulation. But there was nothing about, and we had really great PCPs who were very psychologically minded. But I remember one time I came out and I knew there was a newborn, or an initial visit for a baby that was in foster care with a really complicated history. And I checked in with the PCP, said, oh, we have this little, new guy in room 2. And he said, oh, don't worry about that. I'm a great foster parent. No reason for concern. And I thought, well, that's a real reason for concern, because I already read the chart note, and but it is part of just raising our awareness about how prevalent infant early childhood mental health concerns are, and how we should be concerned when kids have already had that level of trauma exposure. Other thoughts or questions about what I said, or what you're doing in your clinic in terms of early childhood mental health?
One question I had is for the paired well visits. Is it typically that the healthy subspecialists and the pediatrician are there in the appointment together the whole time? Does one more often go first if they're doing it at different times?
Yeah, that's a great question. We, concurrently is best, but obviously the reality of primary care, it doesn't happen like that always. So sometimes the specialist goes first, sometimes the PCP goes first. The goal is to have some overlap where you are, explicitly and implicitly letting the family know that you do work as a team and all of the goals are shared goals that we are all working on. I will say we also defer, not unlike with older kids, right? Some PCPs have real preferences for how that works and what the sort of cadence of the day looks like. Often, again, not unlike, integrated behavioral health with older kids, for families for whom there's lots of complication, whether that's social determinants or parent mental health, or all of the areas of concern that we might see, those are families that often I will go in first and help absorb some of that, and then be able to sort of give a little bit of a summary when the PCP comes in about where we are, or maybe what we worked on in a session in between or something.
That's really helpful. And one other follow-up question with that is, do you have hard and fast criteria you use to stratify like who is getting like the more tier 2 and tier 3 interventions?
Yeah, it's a great question. We give some guidance on that, but we work really hard with sites and practices to help them determine. We don't determine for this reason, because the demographics at every practice is really different, right? Also, I will say that it sometimes is part of a larger maybe evaluation plan that a practice has, right? So maybe they have determined that they're going to focus on, teen moms, or kids coming out of the NICU, or something. So there are lots of site specific things that we don't want to dictate, but we do work really hard with practices to help them distinguish and define what their tier 3 criteria are, which is the highest level of intervention that we would provide. Yeah.
Can you talk some about the differences between a healthy step specialist and a pediatric behavioral health consultant, like in a PCBH model? Because it seems like there's could be a lot of similarities, but I wondered if that would, or I guess I'll let you talk more about it, kind of what the differences might be.
Yeah, I mean, I think honestly, and again, my bias and my preference, because we are implementing PCBH model and I see kids of all ages, right? So a lot of it honestly depends on the panel size. So for many of our practices who have a smaller panel size or more BH manpower, I should say, they really focus on just a downward extension age-wise of what they're already doing in terms of integrated behavioral health for all ages, right? It's about building out that continuum again. So some of it depends on patient panel size. Some of it, I'll be honest, depends on where you are in the country, right? Where we have states that are much more, they have many more behavioral health people available. It's obviously easier to implement. Whereas in states that we have a lot of rural sites, like South Carolina is one of our states. We, are working more around innovation around how do we use telehealth? How do we use paraprofessionals or family partners to help partner with that around supporting some of the implementation of the interventions that families might need. But yeah, I mean, most of our practices are psychologists or LCSWs that are implementing, some LMFT, LPCC, it kind of depends. And then again, support if we have a state where we have a real shortage of licensed behavioral health people, we're looking on how to partner with other practices as well.
Are you finding those specialists, is it just a range, or do they tend to just focus on that 0 to 3 or 0 to 5 age range? Or are you having a lot of folks that kind of are trying to get more specialized in that, but in their actual job, it's a more general, a more generalist approach where they're seeing older kids too?
Yeah, I would say both. I mean, I'd be interested in what everybody here, their experiences, but what we find is that often even some licensed behavioral health people are not comfortable seeing kids under 5. They just don't have a lot of expertise in that area. And so we do a lot to sort of build that out, right? We of course train the entire practice. First of all, at the most basic level, because it is part of that practice transformation, and it's a part of shifting the culture and shifting the way that we think about who the patient is, right? And then we have much more specialized training for the behavioral health person who's going to serve as the healthy step specialist. We have competencies, we have different areas and lots of ongoing professional development. We do webinars, we have our conference, but we have a series called Tiny to Toddler that really helps the specialist walk through every well child visit, where, just to create really good context for the developmental piece, and then also focusing on how to focus on early relational health in those visits, and how to really build parental capacity in those areas. So yeah, it depends. I mean, I kind of liken it to, lots of behavioral health people don't have experience in primary care, and that's a real learning curve. And same thing if you are a behavioral health person that doesn't have particular expertise in early childhood mental health. It's a little bit of a learning curve too. So, and then we have other people who have expertise and only see kids under age 5 serving as the specialist. So it runs the gamut, but I would say the former is more common. Behavioral health people that we train up in early childhood mental health.
Thanks.
As I mentioned during my intro, that we're about to momentarily launch a pilot. We just finished the practice assessment and actually found out this morning that the person we're planning to hire as our healthy step specialist accepted the job offer. So to kind of think a little bit about some of the things that you're saying, Matt, is that she's an LCSW. She did come to us with some experience in 0 to 5 and dyadic models of care, but has not worked in primary care. that was the only person who applied for the job. We offered the job to her for a number of reasons, not because she was the only person who applied with early childhood experience, but we had a lot of great applicants with a lot of wonderful clinical skill, none of whom had worked with children under age 5. And this position here at CHOP was posted as a licensed clinical social worker position for a variety of different reasons. The money people make their decisions, and we did what we had to do with that. So that wasn't, it didn't have to be a clinical social worker in our space. And our program includes clinical social work, psychology, and child and adolescent psychiatry for our integrated care program. This particular position was designated as a clinical social work position, as I said, but most of our clinical social workers here have done more like school age and up. And so, finding someone who had the experience with dyadic models of care was really awesome and kind of rare in our experience here in Philadelphia. We have a number of psychologists in our health system that have early childhood training and experience, and not just those of us who are in integrated primary care, but those folks with the specialist, like early childhood specialty in psychology, tend to end up in our neonatal follow-up program. So like it's being in a system like ours where we have so many ped psych specialties, it kind of, again, we've like selected out the folks with the early childhood specific focus, and they end up in other places. So as we're launching Healthy Steps, we are getting a lot of I've had a few people from the neonatal follow-up program contact me to think about shifts in their careers and getting into more of the primary care kind of space. So we'll see how things change. But the other piece that we're thinking of too is that we in Pennsylvania don't yet have access to any of the awesome policy and billing opportunities that you described, Lisa. And as we head into a somewhat stressful election year here in Pennsylvania, we are still wondering how this is all going to play out in terms of our opportunities at the state level in the future. And so this person that we just hired will be integrated into our integrated care team fully, and she may end up seeing kids over age 3 and in the regular integrated care program as a BHC, particularly as we get Healthy Steps off the ground, because in terms of revenue generation and her productivity expectations and other things, we need to think kind of creatively about the opportunities that we have given our current contracts, constraints, and all these other things. We do, though, in our practice have 3,000 children under the age of 3 in the site where she'll be working. So she'll be plenty busy. And in fact, we're looking for another half-time person at the recommendation of our Healthy Steps colleagues who are guiding us through this process. So it's kind of been, I guess I don't know if I'm totally clearly or not at all clearly describing like what Lisa's saying and sort of our real-time decision-making process as we're trying to think about all of these different decision-making points as we put this thing into practice.
That's super helpful. And just like you said, a real life experience of what you're going through. One of the things that I love about it is that for our clinic, at least, it created a really nice formal structure, but there's also the flexibility to figure out what does this specific clinic need? How does it fit with broader initiatives or the behavioral health workforce that we have or don't have? And you can sort of tailor. So for instance, we have in our community a really big problem with a 1 to 2 year long waiting list with kids for whom social communication is a concern and waiting for an autism evaluation. Ridiculous. So once we started focusing on younger kids, and I was able to create sort of a protocol for doing an autism evaluation, I mean, we decreased our time from 3 years to a month. So there's nice ways to create some innovation even outside the model when you really are, intentionally focused on what are we doing for 0 to 5, what are we doing in the promotion and prevention space, and how to get ahead of it. Finally, we're having this conversation, right? Which is why I love the Surgeon General's report. It's like, yes, we're responding to a behavioral health crisis, but until we start to go upstream and intervene at a much different level, we are never going to get there. But the reality is some of the barriers that we talked about. So we still have a lot of work to do. Yeah, Cody.
Oh, I was just clapping. I was.
I thought you were raising your hand.
No, you are singing my song. I think that's awesome. But while I'm unmuted, I will say that like we don't run formal kind of universal healthy steps at Nationwide Children's Hospital, but we do kind of fill our kind of when we're not consulted, we do go into those early childhood well visits. And we had a paper come out in clinical practice in pediatric psychology a while ago describing how we kind of made a really intentional pivot, not pivot, but intentional focus on our early childhood program for culture and cultural context for our patients that we're seeing. So it's not, like I said, universal in the sense of every single kid or we get in every visit, but it is primary prevention in the fact that we do go in anytime we're not kind of busy with a warm handoff or another clinical concern and have the time and capacity to do so. I was actually kind of curious, and I'm sorry if I missed this, a little bit about like Healthy Steps journey, and maybe it's exactly the things that we talked about with training, skills, and payment. But between going from like, I felt like the early days of Healthy Steps was really more about like community health workers and those kind of providers. And we've now switched into kind of behaviorists and psychologists and social workers, which we have much, much less of. And I've been kind of curious for a universal prevention program at scaling and those kinds of things, kind of what kind of led to that transition and where Healthy Steps plans to go with that? Or are we thinking that this is kind of a moment in time or certain places will have different people? Just because, you know, with workforce shortages and those kinds of things, I'm just kind of curious about that whole thing, and something we've been talking a lot about within our own program about what do we actually need psychologists to be doing and other folks to be doing and those kinds of things. So I was just curious about kind of the history there and kind of where you see it going.
Yeah, it's a great question. So I won't go into all the depth of it, but basically the program was at 0 to 3 and then was back at Boston Medical for a long time and then came back to 0 to 3 in 2015. And since then, there's been a lot of changes, and there's been a lot in a good way, right? To really codify the model, to really shore up the outcomes and the fidelity to the model. It's a good question. We struggle with that piece about the workforce all the time. And so in states, like I mentioned in Massachusetts, the model is actually in a good way because of the value-based payment movement. So this is where we see the payment reform drive the clinical service delivery reform, right? Which is beautiful. So in that model, it is the care team has to be a PCP, a licensed behavioral health provider, and a peer level family partner, community health worker, something. And that's Medicaid dictated. So it does allow, again, anything that's care coordination or systems navigation or connection to resource is really going to live with the family partner level person, so that we can, have the specialist work to the top of their license and be doing direct care. And that's where you really get the capacity to build out some of the innovation and to some of that niche work that I just talked about, like an autism evaluation or a parenting group on whatever you're seeing, but it really allows that capacity. So do I think that's going to change in terms of the model? I don't. I think that it's always the preference to have an experienced licensed behavioral health provider doing this work. But again, the reality, like you said, in some places is that they don't have them. And so we're working on, different states call it different things, but some states have a behavioral health support person, right? Something in the like where we can say, okay, let's train up this provider type to implement and then do more consultation with the licensed behavioral health person. And sometimes we're building that out through telehealth, or it depends again on the state and what the capacity is. But yeah, it's a great question. And in terms of scale, I mean, we are thinking about that all the time because we are now in 220 sites, I think, in like 26 states. And we'll probably double that in the next few years. But we are acutely aware of that. And so the other piece that we're doing is working with states. Like I've been working with Mass Health, which is Medicaid in Massachusetts, around how to attract more behavioral health workforce. Actually, in a state like that, they have many licensed behavioral health providers. They're just not in the Medicaid space. They're in private practice where they can make a lot more money, right? So part of it is how do we incentivize, how do we advocate for better rates so that people do work in places where we can serve families with Medicaid. They're doing loan forgiveness. There's a lot of innovation that we're trying to work with state Medicaids around how to attract more behavioral health professionals to primary care. Other questions? I'm mindful of time. I know Rachel we have an article too. So I don't know if there are other questions or comments, or we should move to the research corner.
Jessica, I think you were unmuting like twice, especially when I asked my question too. So I didn't mean to talk over you.
Oh, you're fine. I was just gonna, in terms of the like financial sustainability piece, I just wanted to share one thing that we're looking at as a very small program. We're just like a small private practice. So one thing I'm looking at is kind of looking at our overall behavioral health team being kind of financially sustainable as opposed to any one component of it. So if we do end up getting a healthy step specialist, what I anticipate is they're going to bring in less revenue, but they will also be taking the postpartum depression visits right now that we just like completely eat the cost of. So that hopefully, so our behavioral health more general behavioral health consultants will bring in more income. So hopefully the two will balance rather than, yeah, I think right now in New York State, it is tricky to have that person be completely financially neutral, which is where we are at right now as a team, we're slightly net positive. So
that's a great point though, Jessica, just how to couch it. I mean, many of our sites are starting honestly with philanthropic funding. I mean, or they are doing exactly what you said. They're a licensed behavioral health person who sees all ages. And as we work to advocate in the state, they're seeing that, they're billing for kids, the older kids, and eating some of the cost. But there are more and more pathways, as I sort of shared, that are opening up. Value-based payments coming in New York, Jessica. There are so many exciting things happening. So I think it'll be sustainable there. But yeah, sustainability is an ongoing concern for sure for prevention. All right, shall I turn it over to you, Rachel?
Sure, thank you. And Lisa also picked out this article, so I think kind of complements. It was really great to hear about what you've been involved in, and you mentioned a lot about practice transformation, which is what this article is about. So I'll share briefly and see if that kind of opens up discussion a little bit more. Let me open up my PowerPoint here. All right, let's start from the beginning here. So, so this article is describing how pediatric practices can build their capacity for early childhood behavioral health services. This was a grant-funded program, and it was called Behavioral Health in Pediatric Populations, BHIP. This was a program that was implemented in the Metro Denver area, and it was grant funded in support, and it involves, as we'll talk about, pediatric psychologists, primary care pediatricians, and some other kind of people who provide technical assistance. I think that was also a theme that kind of came up in terms of describing practice transformation. But essentially, they were trying to expand their early childhood behavioral health services, all the lovely things that Lisa was talking about that she does. This, of course, can involve screening and the developmental screening or some behavioral health screening, prevention and health promotion, just as we discussed in terms of healthy steps, universal prevention kind of work. They're also looking to expand what would be maybe considered kind of the typical primary care integration services, so providing brief consultation or intervention services for families. And they also wanted to increase care coordination, system navigations, again, some of the services that we've kind of discussed thus far. So they had a team of pediatric psychologists, and as I mentioned, the technical assistance professionals. So this included pediatricians, this included a project coordinator. I'm going to walk through kind of the steps that they took to help enhance these pediatric practices. So they had 9 practices involved in this program 2 FQHCs for private practices and 3 nonprofit community practices. They were chosen for implementation essentially based upon whether or not they thought they would be ready for this type of behavioral health services. They didn't necessarily have to have a behavioral health provider, and that could be part of the goals in terms of their practice transformation is to hire. And so we'll talk a little bit about that, but ideally they chose practices who were ready, who had perhaps a behavioral health champion and those on board to start. So in terms of the technical assistance that they provided, this was a 2.5-year period program. They got monthly technical assistance, essentially sessions, and they were individualized to basically talk through whatever their goal was in terms of the service that they're providing. What are the barriers? How do they implement? How do they kind of communicate this to staff? Other kind of technical assistance types of things in terms of the how of implementation. And they also had quarterly half-day learning collaborative sessions. So this is when all the practices kind of came together and there's kind of content delivered. So as I mentioned, in terms of the individualized technical assistance, it really just depended, of course, upon the practice and what they needed. But when we mean technical, it's like, how do we implement with the EHR, the billing questions that were asked here, workflow, how do you collect data and track your progress across time? How do you communicate the changes in terms of your processes and workflow to your practice? So lots of like foundational assistance to really help these practices take hold. In terms of kind of the planning and the implementation, so at 6 months, they had a planning period, basically just to get them ready to collect data and or to identify basically what their goal was for their first year. Their first year implementation, they had to choose 2 of the 4 early childhood behavioral health services. So whether it was screening, the case-based consultation, prevention health promotion, or the care coordination systems navigation. Again, as you see, they got funding, money to implement. And then year 2, as they're collecting data across time, they had to kind of reorient their goals. And they encouraged the practices to focus more on intervention or prevention services within the practices. So in terms of data, just to give a broad overview, at baseline, the behavioral health visits across the 9 practices for ages 0 to 5 were 11% of visits, and that increased to 19% to year 1 and then 23% to year 2. So you can see a large change across time. In terms of the strategies, screening was number 1. That was reported the most by the practices, and you can kind of see the spread in terms of the other interventions. When you take out screening, you can help to see more of the spread. So if they weren't screening, the next service that they're most likely implementing was prevention or health promotion. And this also kind of differed by the practice type in terms of the facility. So for instance, they found that FQHCs were more likely to be implementing prevention, health promotion. Taking out screening helps a lot. I thought this was an easier graph to kind of interpret, and this is all of the other practices, and you can kind of see the change across time, such that the intervention, prevention, care coordination, the spread becomes a little bit more, you see more of the services provided across year 1 and year 2. And of course, they were more targeted across time as well. I know I have got like 3 minutes left, but essentially this article demonstrated data-driven transformation. You individualize this implementation can be quite successful. And so opening up to how can you transform your practice to implement more early childhood behavioral health services. This is the citation. It was article in Clinical Practice in Pediatric Psychology. I'll stop my share because I know we're at the end. Questions, thoughts people had. Thanks, Lisa, for choosing the article this time. People ready to transform their practice. Yes, I can send the article. We can send it out in the notes for sure.
Thank you, Rachel, and thanks, Lisa, so much for y'all both for helping facilitate today. I thought it was really important and impactful, and you know, I think I like how you ended it, Rachel, with just how, you know, how do you start to increase your practice's ability to reach this age range of kids? And maybe it's through starting the Healthy Steps program. Maybe it's just through some small practical steps that your team can do through some kind of a PDSA cycle or something to target a group that that you know in your practice really is missing out. So, and I loved how you kind of framed it in the barriers to the Surgeon General's report too, Lisa. Cody and I have been trying to think about that a lot recently, and I think it sounds like there's several states that are headed in the right direction in terms of resolving some of those barriers. So that's great. Anybody have any last thoughts before we head out? All right. Well, thank you all again so much for coming. Lisa, thanks so much. And we will see you next month.